Okay, so in Module 6, we're going to be discussing behavioral observations, which are really the crux of single system design. For your project specifically, it's usually going to be your main dependent variable is your behavioral observation. I'm also going to be covering a couple other types of measurements commonly used in single system design, both individualized rating scales and standardized measures. So something unique to the social sciences are quantifying behaviors. So what exactly are behaviors? It can be basically any kind of action somebody's taking. I've always been taught as a psychologist that you can never not be behaving. You're always doing something, whether it just be sitting, whether it be thinking. People are always behaving. And also every behavior has meaning to the behavior. So everything that we do has some kind of meaning and is in some way modifiable and within somebody's control. That gives us a lot of power as clinicians in order to help people to live higher quality of life and be able to make modifications to those behaviors. So behaviors can be measured either directly. It can be through somebody's self-report through a behavioral observation measure. For instance, if you're going to be working on somebody with number of cigarettes smoked per day, they can fill out how many cigarettes they smoked, and that's pretty easy behavior to measure. Behaviors can be measured either retrospectively or prospectively. Generally, I think about baselining is done being often retrospective type of measure. So if somebody was to estimate the amount of time that they spent going to the gym during a baseline phase, it's often done retrospectively because there are certain ethical considerations that come with postponing an intervention. So typically people are asked to think about what their baseline behavior was before an intervention started. Behaviors can be measured objectively by a third party. This is often done for people who work with children. Might be like a behavioral observation within a classroom setting to see how many disruptive behaviors there are, number of minutes the student's on task, whatever it may be. So behavioral observations most often count how often a certain behavior occurs. And this should really match your operationally defined problem. So if we're talking about operationally defining your conceptual problem, it could be quantifying how often somebody is picking at their fingers or having urges to drink alcohol or whatever it may be. Your behavioral observation is essentially quantifying your operationally defined problem. Behavioral observation measures can also record the duration or amount of a behavior. So it can be the amount of time spent studying, amount of time spent actively exercising within a gym. And I would say that something like study time is better to measure on a level of duration because not just number of times that somebody studied, but the amount of time that they spent studying is probably going to give you more accurate results of what their actual behavior was. Instead of doing number of times somebody goes to the gym, because you could go to the gym for a couple minutes and not really do anything and leave, it makes more sense to measure that on more of a duration or interval as opposed to frequency. So the nice thing about behavioral observations is they can be performed by the client, the practitioner, a friend, roommate, relevant other, spouse, whoever it may be. And they're typically pretty simple instruments. And you may have already had some experience doing a behavioral observation and not even realized it. So for instance, sometimes people are on like a specific type of diet and they're measuring the number of calories intake per day, or maybe they're trying to increase the number of ounces of water consumed per day. So that would just be a simple behavioral observation measure. And oftentimes people have already been doing these without really even realizing it. So in order to get accurate and valid results, we have to first define or specify the behavior as best as we can in terms of a beginning and an end. So some examples could be number of arguments per week. So what exactly is an argument? Is it raising voice? Is it screaming? Is there a difference between an argument and a disagreement? Certainly, we would have to spend a good amount of time defining what exactly constitutes an argument, which is a little bit more difficult than some things in the natural sciences. Also, what constitutes studying? I'm sure we can all think of times where we were in a library in front of a book, but not really studying. So what exactly is studying? Is it completely focused, minimizing distractions? And how would we measure it even if we did spend 60 minutes studying and 15 minutes were spent on the phone or whatever it may be? What constitutes studying in that 60 minutes and what doesn't? Would that count as 45 minutes? Would we count it as 30 minutes? All things to consider when we're doing behavioral observation measures. So worth pointing out that regardless if you're doing frequency, duration, You can do continuous recordings or behavioral sampling. So an example I know that I've done in the past is I've worked in some public schools and done some behavioral sampling. So for instance, if I'm only able to observe a child I'm working with for a couple hours out of the week, I might just do behavioral sampling, like trying to get an idea of the amount of times that a student's having outbursts or off task or whatever it may be, doing a sample of that behavior, and then kind of documenting it as a neutral third-party observer. Sometimes those naturalistic observations can be a little bit even more objective than maybe a teacher's perception, because lots of times if we put the onus on the teacher to record a certain type of behavior, they're also doing a bunch of other stuff and maybe too busy to try to do an additional step of a behavioral observation. So as a clinician within a school-based setting, you might be doing some behavioral sampling and third-party measurements of a operationally defined problem of a student. So back to the big picture practice evaluation. As we are going through measurement, now that we've discussed behavioral observations, I'd like to spend a little bit more time on individualized rating scales and standardized measures. So of the 4 type of measurements that we're going to be doing for this course, I'd like for you to get experience with at least 2 of these 4 behavioral observation measures: individualized rating scales, standardized measures, and logs. So individualized rating scales are a measurement method that you might already be somewhat familiar with. Oftentimes they're just on a scale of intensity, so it might be a pain scale. Tell me on a scale of 1 to 10, how intense is the pain that you're experiencing right now? On a scale of 1 to 5, how would you rate your satisfaction with your treatment that you received today? Something that you've probably already been somewhat exposed to and hopefully have a little bit of experience with. So individualized rating scales can measure the intensity of a problem or a goal. Some examples might be a seriousness of a client's problem. On a scale of 1 to 10, how much is this impacting your quality of life? An example might be importance of changing a behavior. So you could ask like a motivational interviewing type of question on a scale of 1 to 5, how important is it for you to change this behavior? And you might find that somebody is really not that motivated and they're kind of mandated into treatment. Certainly something that we see a lot. So you might assume that somebody is motivated on a 5 to stop consuming alcohol, but maybe doing further assessment, you might realize that they're somewhat more ambivalent about it. Individualized rating scales can also measure the extent of a problem and how confident somebody is that they're going to be able to address the problem, or how at ease they are with addressing the issue. So this is just a really basic example of an individualized rating scale. Something like on a scale of 1 to 9, how important it is for you to change your alcohol and drug behavior, with 1 being not important at all and 9 being extremely important. So this would give you a gauge of how important or how meaningful it is to the client to change their behavior, and maybe a good thing to ask kind of like during a clinical intake, maybe something that you're already doing. How important is this for you to change? How willing are you to engage in change behaviors? And maybe how likely do you think it is that you'll be able to reach your goal? Individualized rating scales are something that you would develop in order to get at the type of questions that you might be interested in. So individualized rating scales in comparison to behavioral observations are generally less valid, less reliable, and less direct. So you might ask, why would you be using these if they weren't so reliable or valid? So despite not being standardized, it still gives us a good idea of the extent or intensity of a problem. The key word here being individualized. So as opposed to a standardized measure that might not be specifically tailored to the client's problem or even really consider cultural implications, an individualized rating scale can help us more richly and directly capture the client problem that we're trying to address. And as a practitioner, you can create an individualized rating scale in conjunction with a client versus a standardized measure that might be already in existence. An individualized rating scale is something that you can work with a client to get their feedback and kind of see if you're on the right path to accurately assessing their problem as they view it, and kind of looking at specific ways in which you can be helpful to tailor your intervention and your measurements to their needs. So an example here might even be working with kids, like on a scale of 0 hurt to 5 hurt, it hurts a lot. I can think of an example where I've taken my daughter to the doctor recently for a strep throat. And if I were to ask my daughter on a scale of 1 to 10, how much does your throat hurt? She would just kind of give me a funny look. Versus if you had an individualized rating scale that was more adapted for working with children, you might incorporate bases or maybe use language that a kid could understand better than an adult might. So these can be tailored to the specific client population that you're working with, both within age, developmental level, culture, socioeconomic status, or whatever it may be. So as you're developing an individualized rating scale, obviously selecting the rating dimension, and sometimes there might be more than one dimension that you want to actually get at. So if you're creating a multi-dimensional individualized rating scale, potentially for maybe mood-related symptoms, you might want to hit different dimensions of mood, maybe loss of interest on a scale of 1 to 5, enjoyment in life on a scale of 1 to 5, motivation on a scale of 1 to 10, whatever it may be. You can tailor these to the specific types of targets that the client would hope to address. And just kind of regarding the number of response categories, generally people do it on a scale of 1 to 5, 1 to 10. The issue with having too little is you're not going to catch a really good range. So I would say it's generally best to keep it within like, on the slim side, maybe like 4 to 5, and on the higher end, maybe like right around 10. Because if you have like on a scale of 1 to 20, what's the real difference between a 13 and a 14? Probably not that much difference. So I would say it's generally best to keep it between 5 and 10. Also, an important comment here is to try to keep equidistant response categories. So if you're going to do 1 through 5, the difference between 2 and 3 should be the same as 4 and 5. So the intervals between steps should be pretty equal across the scale. But as you probably can imagine, a lot of people tend to do extremes on here. So sometimes it's good to put anchors in so that people know what exactly each number means. So pardon the gruesome image here, but I know some people had this up in their office at the last hospital that I worked at. And typically the reason when I worked in the pain clinic, almost everybody rated their pain at a 10, no matter how severe it appeared on the outside. So I thought it was good to try to give maybe like, even for adults, even though it was kind of humorous, maybe somebody, if they said they were at a 10, but they weren't even grimacing on the outside, I might say a 10, you'd probably be making some types of physical suggestions that you're in pain, whether it be crying or sobbing or having difficulty breathing. So I think even for adults, it's a good idea to try to give some anchors so that people have an idea of what a 10 actually is. Okay, so with individualized rating scales, you can also see how you might chart this over time. So this is an intensity of feelings of self-harm, which is obviously a serious issue that you would want to keep pretty good tabs on. So not self-harming behaviors, but intensity of feelings of wanting to self-harm. So you could see here maybe during the first week, they rated their intensity to self-harm at a 7 versus as you go down to like week 8 or 9, their intensity dropped down to like a 5, which there was still urges there, but sometimes it's important to acknowledge that the urges are less intense and maybe a little bit more manageable and easier for the client to deal with. So kind of back to anchors here. This is a thermometer of anger that I've shown kids in the past. So you can kind of give like different faces or different meanings to the different levels. Sometimes with adults you can use numbers. Sometimes kids you have to use like different kind of like almost like emojis or something like that, so that they can rate their level of emotional distress. And sometimes utilizing that face can help them to identify what emotion they are feeling. So just a demonstration here might be how important would you say it is to make some changes in your whatever it may be on a scale of 0 to 10. Maybe just think about some ideas that you've had for your own single system design project and think that you might want to change. So just kind of think about on a 0 to 10 how important it is for you to change that, whether it be going to the gym and spending more minutes exercising each week or each day, or potentially spending more minutes studying each night or sleeping each night. So on a scale of 1 to 10, how important it is for you. And this could be a good question to ask a client too. On a scale of 1 to 10, how important it is to you, and on a scale of 1 to 10, how willing are you to devote more time or effort to this? And to follow up, more of like a motivational interviewing thing is, why are you not at a 0? And also, what would it take for you to be at a higher number? So if somebody said that I'm like thinking about changing this at like a 3, maybe they're in like a pre-contemplation phase. or they're in a contemplation phase and they're just not ready to take action yet. So you might want to follow up, like, what would it take for you to be a little bit more motivated here? And why would you say that you're not at a 0, and kind of address some of that ambivalence? So standardized measures are a little bit more formal along the lines of single system design. So standardized measures are something that's been published. There's already norms on the validity and reliability of the measure, something that you'd probably find online or maybe in the library somewhere. So you can select a standardized measure that specifically addresses the client concern that you're trying to get at. Sometimes it's good to do kind of like mental health symptoms with a standardized measure, because then it directly relates to the DSM or research standards within the field on that area. So an example of something that I use pretty commonly is the geriatric depression scale. So it's specific to a population, geriatrics, that I work with, and also specific to a mental health disorder. So as opposed to coming up with an individualized rating scale, a geriatric depression measure actually gets at the exact concept or construct that I'm trying to measure, and it's already validated and normed with a large population. So I know that I'm getting at and measuring exactly what I'm trying to measure, and it's a valid, reliable tool to get at geriatric depression. And I've posted the geriatric depression scale to the website, so you can kind of take a look over it yourself if you're interested. So when it comes to selecting a standardized measure, again, we want to think about the reliability and validity of the measure, which should be published within the article itself. So when you're pulling up a standardized measure, if it is standardized, that means that it's been peer reviewed, and there's been processes to ensure that it's actually an accurate measure of what it's proposing to measure. The reliability and validity of that measure should be published within the tool itself. It's also important to think about the ease of use, because some standardized measures are really long and hard to administer multiple times, and some are really brief, maybe just a few items or so. So kind of keep in mind how easy it is for somebody to use, or maybe how difficult it is for them to use. And even developmental level, if somebody's got dementia, it might not be a good tool, or if somebody's too young, it might not be a good tool. Regarding accessibility, I would also say that some you have to pay for, versus others are free. So I would encourage you to think about which ones are public domain and which ones might be easily accessible either through your organization or just through a Google search. And a lot of scales have cut points. So if somebody scores above a certain score or gets above a certain total, then that might be a good screener for a certain type of disorder or a certain type of diagnostic criteria. Over time in administering it, you might find that somebody first met a cut point for like maybe a PHQ-9, they got above the cut point, and maybe after several meetings with them, they no longer meet the cut point. So it's a good thing for you to keep documentation of within your notes, and also a good tool for you if you're utilizing single system design. So there's a few different forms of standardized measures. We've got screening measures, like I said, like the PHQ is just going to tell you whether somebody may or may not be within a clinical level of severity of symptoms. There's diagnostic measures. So again, if you were going to give somebody like a geriatric depression scale, that's getting at a specific diagnosis of depression within a geriatric population. And then there's more thorough assessment measures, maybe something more formalized, like a personality measure, like a MMPI, or an intelligence measure, like a WACE, something that gets at more of like a multidimensional assessment. Probably something not to do for a single system design, but potentially for a baseline. For your project, you might want to do some of these diagnostic or screening measures pre-intervention and post-intervention. Maybe not on a daily basis, but sometimes it's a good idea to look at what a problem was like before there was the single system design compared to like after the intervention's complete. And that's actually becoming more of a standard of practice. And I see it more and more in the hospitals that I work with. People want to have some kind of quantifiable data to see whether or not we're actually getting at the goals that we intended to, and whether or not it's a good resource for us to have more mental health professionals via social work or psychology or whatever it may be. And just kind of like a closing thought here, when we were talking about reliability and validity, we want our measures to be as valid as possible. And one way of thinking about this is we want to have as many true positives as we can. So we want it to be sensitive enough that it picks up a disorder within a population or a condition within a population. So if we had a measure of post-traumatic stress, we would want that measure to be able to capture people who had post-traumatic stress symptoms, but also not to have false positives to pick up people who don't have it. Likewise, we would want people who do not have post-traumatic stress to screen negative, and if they were screening positive, we would have some false positives here. So our goal is to decrease false negatives and false positives by accurately screening people with the disorder, and being able to separate those or distinguish those from people who don't meet criteria for a certain disorder.